and welcome. I'm Christy Newton, co-facilitator of the TBC at UBC Network. I am the Associate Vice President Health and an Associate Professor in the Department of Family Practice within the Faculty of Medicine. And today, my co-facilitator, Lee Yates, a Clinical Associate Professor in UBC's Midwifery Program, also in the Department of Family Practice and in the Faculty of Medicine, was called in for a delivery, so is unable to join us. And we will miss her insights. However, I'm really looking forward to hearing from our panel today. So thank you for joining our TBC at UBC Network event. Before we start, I would like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Tsi'olks Okanagan Nation. I'd also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you're joining us today from many places. And I acknowledge the traditional owners and caretakers of those lands. I'd also like to acknowledge that in my work at UBC, I have a responsibility to disrupt, dismantle, and decolonize the health system. I have committed to address the consequences of colonization, and I strive every day to support reconciliation. I am joining you as a guest from the unceded shared territories of the Coast Salish people in what is now called Port Moody, and I appreciate the generosity of the current generation of the Tsleil-Waututh, Musqueam, Squamish, Coquitlam, Katzie, Qayqayt, and Stolo peoples who welcome me to occupy and live on their traditional unceded land. Please feel free to share the lands from which you are attending in the chat today. To start, a bit about the network for those who may be new. The TBC at UBC Network is supported by UBC Health, which works under the Office of the Vice President Health to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaboration across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy to ultimately address inequities and improve the systems that foster and support health. The TBC at UBC Network convenes health professionals and leaders, community members, academics, and policymakers to bring forward questions and ideas important for team-based care in British Columbia. The network supports and complements province-wide efforts to enhance team-based care in BC by focusing on education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and connect their efforts. Before we begin, I'd like to do a poll to get a sense of who is joining us today for the session. So you should see the question of what perspectives do you bring to the conversation today? Wow, that's great. It's nice to see that there is representation across all of the, including, I'd be curious what the other is. But it's wonderful cross-sector representation, so thank you. Okay. Now, today's session is focusing on examining the space between professions through the lens of a critical incident. Oh, there we go. There are the poll results.
Not right now. Because we got more.
And I'm just going to stop sharing now. There we go. My screen. There we go. Okay. So the space between professions, communication, processes, role clarification, conflict resolution, collaborative leadership is integral to team-based care. Special attention to roles and relationships in the team need to be prioritized, especially in addressing critical incidents. Intentional training in team processes, such as communication between team members, can optimize patient safety and achieve continuous quality improvement in team-based care. And often, not enough time and commitment is made to the space between professions. So today's session format is going to follow the following breakdown. So we're going to start with a presentation from our panel of speakers, and then we'll share some different ways to engage with the TBC at UBC network before we transition to small group breakout sessions to dive a little deeper into what the panel has presented, looking specifically at practice innovation, education, and research. And then we'll come back together, perhaps ask a couple of last-minute burning questions of the panel, perhaps highlight something or an aha moment that came forward in the breakout session, and then we'll wrap up. So I think you've heard enough from me, and I'm going to introduce our panelists. So our panelists today are from Island Health, Dr. Pham, Co-Medical Director, South Island Urgent and Primary Care Centers, Jennifer Matheson Parkhill, Site Director, South Island Urgent and Primary Care Centers, Stephanie Acevedo, Clinical Nurse Leader for the South Island Urgent and Primary Care Centers, and Nikki Bourgeois, Clinical Nurse Educator with the Primary Care Clinical Support Team in Island Health. So please take it away.
All right. Thank you so much, Christy, for the introductions. And we're excited to be sharing with all of you. I flipped through the participant list and saw many of my teammates here from Victoria. So shout out to everyone who's taking their lunchtime to join from their clinical work. And we're going to do this in true team-based fashion as a team presentation. So I'll start off first and set the stage. Then Nikki, Steph, and Jennifer will bring in their different team perspectives. And then we'll turn it to all of you for hopefully a lively small group discussion. And we named this the space in between because we haven't really spent a lot of time as rapidly growing teams on those moments of silence that might arise when we do need to ask for advice when something happens and we don't know how to ask that question. And so that's why we called our presentation The Space in Between. In terms of disclosures and conflict of interest, none to declare for all four of us. I did fit in here that I do bring the bias. I have been faculty at the University of Toronto for 20 years. And so the themes of patient safety, quality improvement, and leadership development are things that I care passionately about. And so if it gets a little bit too academic, just shut off the mic on me. It flows in from there. And just to set the stage, what is the problem that we face here in Victoria? For all of you who aren't from our beautiful island, 6 urgent and primary care centers have received funding approval in 2019, really to tackle the problem that 20% of our South Island population around Victoria and surroundings have lost their family doctors, and many of the patients that we see will tell us that with much, pain, that they haven't had a family doctor in 7, in 8 years. And so while we're actively trying to recruit and increase our capacities, we will not solve that problem in a long while. And so our problem really at hand is, how can we increase access to primary care services, all of them, chronic disease management, preventative care, and all of the other typical services that family practice does, while we're trying to get more longitudinal physicians onto the island. So the learning objectives today, is already outlined within the title, are really that within the space of interprofessional team, I think a lot of thinking has gone into thinking around how to maximize the scope of the various professions. How do we maximize the role of nursing, nurse practitioners, social workers, pharmacy? But we haven't stood still to really think about, have we invested into skills training around communication between our various professional groups? And are there different ways of communicating in different professional groups? Do nurses prefer one style? Do doctors prefer a different style? And then do we create a culture? And does the culture of the team maybe differ by professional groups within each of the individual clinic sites? And does the physical design of our space matter? And so this is kind of the graphic that I put out there for all of you. We have a couple of other clinics coming on board on the island, and we've spent a lot of time thinking about, how do you create collaborative spaces? Should it be as busy as a train station, or should it be a large space where the team can come together regularly? Or does your team end up being crowded, waiting outside the examination rooms in the hallway in order to have meaningful discussions around a patient case? So physical design and creating a space where we physically meet actually matters. I will be looking at some of the literature review, and for those of you who are academics and researchers and like to look up things, I will point you towards either Thomas Bodenheimer's 2019 paper called Building Powerful Primary Care Teams, or obviously Dr. Edward Wagner's work on the LEAP project, and the website www.improvingprimarycare.org, which I find is actually super helpful, really looking at outstanding US-based primary care teams and how they've excelled and what are the critical core elements that make a team successful. But both of them really highlight and bring together that high-performing teams meet often to maximize patient flow and to discuss care at patient case conferences. So to me, as a busy family doc, always running from one room to the next, it gives you permission to really say, oh, taking explicit time to sit still, to come together as a team, actually creates better patient care and stronger teams. And as I highlighted here, it does. I saw that within the poll that Christy just did at the very beginning, we have about 50% of the audience members here today who are clinicians. And I saw by looking through the participant list, some of you are family physicians just like me. The role of the primary care provider, and in particular of the family physician within a team, actually also requires change. And I think particularly here in British Columbia, team-based care is still in its younger years. And so it requires a proactive reshaping of how we understand ourselves as team leads, as physicians within a team. That much of the work we do as team leads is really knowing the roles and expertise of each member of our team well, and moving our whole team towards a culture of mutual respect and trust between all the team members, and developing systems that allows us to come together and communicate effectively. And that's what today's presentation really is about. I did put out these pictures between a lone cowboy and pit crews, just in case you do like a Thuy-Nga Wonders paper on that, because he too highlights the change that is required, particularly in our profession as family physicians. I have attended grand rounds where colleagues might speak disparagingly about the extended scope that nurse practitioners, pharmacists, nurses have now within primary care. And I do think that too is important for us to be aware of as a professional group as we move towards powerful primary care teams, that the language we bring to the table is empowering our team members and not robbing them and disrespectful. I come from Ontario, as I said earlier, and primary care teams were rolled out there in 2005. That's actually when I graduated as a family practice resident, and researched there on, solid primary care teams and what builds solid primary care teams has been going on just a little bit longer. And so the paper here by Carol Mulder and her team from, I think, Kingston, that case, brought various teams together and just asked them what are some of the top 3 elements that you as team members think are crucial for effective collaboration. And no surprise, the top 3 are communication, communication, and communication, that we treat patients together between different disciplines, between myself and the nurse on the team, between the social worker and myself on the team, or between the nurse and the mental health consultant, and that there be patient-based conferences on those patients that benefit from it. I did put a sidekick in and a piece of advertisement for the just published Our Care initiative that I know Christy and I had the pleasure of being together with in June. And if there are any other members of you here that have participated in the BC panel on the Our Care initiative, a big shout out there to that. Our team had the pleasure of presenting on team-based primary care there. And patient panels across Canada have been very strongly expressing themselves that they wish for an expansion of team-based primary care and for stronger funding into primary care across our country. That shouldn't strike anyone as news. So now back to the voices of my team members. The first one I'm going to invite onto the mic is Nikki.
Thanks, Kia. So I'm just going to chat a little bit about effective team huddles. So let's talk about what is a huddle. A huddle is a short 5 to 15 minute briefing designed to bring team members together to ensure that all team members have the information they require to effectively, efficiently, and successfully do their job. So team huddles create collective awareness, fosters team collaboration. It's a point where you can share information, celebrate success, and reinforce common goals. Effective team huddles will help create strong, purposeful teams that provide quality patient care. So you might ask, what does a huddle look like and what does it sound like? So a structured team huddle should occur at the same time each day in the same designated space and with as many of the team members in attendance as possible. A huddle is led by a designated individual, often the charge nurse, and facilitates discussion about information such as staffing, clinic flow, kudos, and announcements. So let's just take a little bit of a closer look at staffing. So who are the staff working that day? What are their roles, their areas of specialty, or their interests? So for example, Jessica is a certified practice nurse who can perform STI testing and treatment. Karen's a family practitioner who specializes in pediatrics, and Mike is a nurse practitioner who has an interest in suturing. So why is this information important? This information is important to the MOAs when booking clients in for appointments. So for example, Jessica is able to perform STI testing and treatments, therefore opening up a spot for a provider visit. Is the clinic at baseline staffing for the day is another question to ask. If it's not, do pre-booked appointments need to be rescheduled or adjusted? What is the clinic flow going to look like for the day? So how many patients can we accommodate today? What are our goals? Are we running any special programs today that we need to consider? For example, a lumps and bumps clinic, a nurse-led CV screening clinic, cervical cancer screening clinic, or perhaps a pediatric respiratory surge clinic. Do any team members require shared appointments? For example, does social work have a client or MHSU have a client that they will see first, but they're pretty sure a provider is going to need to see for support afterwards. Lastly, kudos and announcements. An effective team huddle is a great opportunity to come together and to share positive feedback and kudos with staff. It's also a place to share important announcements like upcoming staff events, educational opportunities, communication memos, etc. So at this point, I'd like to hand it over to Stephanie to discuss RN scope optimization.
Thank you, Nikki. I'm here to talk about a very significant factor in team-based care, role clarity. As straightforward as it may sound, there's actually quite a few overlooked aspects to it, so super simple to begin with. What is role clarity? Well, role clarity just means that each member of the team understands and is aware of what their responsibilities and tasks are to be able to accomplish the specific goal in providing excellent patient care. So why is this role clarity important? Ordering this from most impactful, in my opinion at least, is number one, to know each profession's scope of practice. This is very important because knowing our own and each other's scope of practice is the first step in acknowledging team-based care. Simply from defining the differences in practices, team-based care becomes a versatile, productive way of patient care. Not only are we able to ensure the proper care with the proper team member, team-based care optimizes and enhances the best of everyone's unique skills and abilities in their fields. Number two, do not waste time, both for staff and patients. Each individual's time is precious. Let's not take this for granted, but utilize it efficiently and effectively. Number three, promote effective communication. Just as Tia mentioned, communication is crucial for team-based care. Whether it be having a huddle at the start of the shift, which Nikki just talked about, to having team meetings, whether it's a once a month, collaborating about how we can support a patient in our care conferences, and even debriefing after an incident. Communication brings us all together, meaning it is the basis of a well-structured and healthy team. Number four, to avoid confusion among the team. Who's doing what? Who's in charge? Who is my go-to for any concerns? Questions like this can arise anytime during our day. So role clarity helps guide the team to clear any doubts or unknown factors. Number five, to avoid gaps in patient services. If staff knows what services are available for the patient, who is doing what and when, then we can facilitate a better patient journey each time. And number six, to avoid duplication and overlapping of roles. Knowing each person's role solidifies the team in an organized and safely controlled fashion in order to properly give patients the best care. The next question is, who benefits if there is role clarity within the teams? The patient, the individual staff, and the whole team. If everyone in the team is aware and involved in their roles, the patient will be happy with the care that they have received. The last question would be, how does starting with the role clarity during the setup benefit the team? The answer would be, we can build the staff depending on what the community needs, location, and demographic-wise. We can collaborate and reach out to the different resources available for both external and internal in our communities. We can maximize each profession's time and capacity to be able to provide the ideal care to the people that we serve. We are able to distribute the work within the team and establish each individual's roles first. And last but not least, provide a wraparound care for each patient that we see in our clinics. That's it for me. Now I give it back to Dr. Pham. Thank you.
Thanks, Steph. All right, now a slight switching gear from thinking about the space you've created to collaborate and to communicate to when in fact something arises within our clinics that requires urgent attention. And so in the next little bit, I'm going to refer back to an incident that, I've witnessed within my many different roles over the last 20 years and the tools we've used. There are two in particular that I'd like to share with you that I think aren't necessarily that common the days I graduated, but certainly something that we've been working together across the University of Toronto and the University of Calgary to promote within team-based care, not just in primary care. So the first one is called the Team Scheme for Team Collaboration. And as you see here, you can just Google it, University of Calgary Team Scheme. It's a fabulous model that was adapted by the National Interprofessional Competency Framework and Team Steps. And it essentially, when you look here on top across the red 4 columns, it divides the way you should approach team-based care into 4 categories. The first one is, what is the role of leadership or membership? The second one is communication, and we'll dive into that in a little bit deeper in a second. The third one, and that's a really crucial one that I think you need to be aware of as a team and that we need to practice, is situation monitoring. And obviously, those of you who renew their BCLS, ACLS regularly, it's a crucial one to always play around with. But in primary care, we might not be thinking about that so often. In a family practices office, emergencies don't happen that commonly. Sometimes they do happen, and then you need to be ready. And then lastly, is there a way, particularly in teams, how we can come together and do collaborative decision-making, and what would be some categories around that? So I put the arrow onto situation monitoring. Situations and challenges are anticipated, and you call for help early. And that's, I think, a crucial one when our own little office room, something happens, a patient starts turning blue. Who do I call for help? How do I call for help? And how many people need to be ready to jump? So these are some of the things where as a team you want to have designated that in the morning if you work as a team, and that there is continuous situation monitoring, how to move forward, always a step ahead. I sometimes get asked I wouldn't agree with how Tia did this. Do I step in? Do I say something? Yes, you should. Within a really good team, everyone can speak up. And so that's in the category collaborative decision-making. Members are assertive when necessary to advocate for the patient's best interest. And so anyone should feel comfortable saying, hey, Tia, your hands are shaking, move over. I'll take care of this one. Why don't you go and call the ambulance? Communication. Really clear communication. Call out names, use names. Hey, Tia, can you do this? Can you go and get help? Where is the bag? And that you do closed loop communication, just like we've been taught in ACLS and BCLS. I did this. I called the ambulance. They said it'll be 10 minutes. And then leadership. So again, whoever is the team lead, it doesn't matter what your professional designation. People will step in, help out, designate someone else so that someone else can do something else. So the leader isn't task focused, but remains and has a large broad focus. So I can only recommend sitting with that as a scheme and thinking about, are there different ways that you can walk through that as a team so that everyone is really clear about that. And if you want it, there are great simulations that the University of Calgary has devised that are really a lot of fun to do. And I would love to bring Greg's wings back to this network next year, if you allow me. So one of the things within the team scheme, and there's a great publication by the CMPA and within quality safety by the British Medical Journal as well, and I put the references down there, is really that permission to use critical language, and that you are invited. In fact, you are asked to be assertive because it's about patient safety. And I love the language that has been put within there. I need you now. Something is wrong and I need your help. This is urgent. And there's a 2-challenge rule. You say it once, and maybe the first time you say it, you're kind of timid because you feel a bit shy about it. But you have to say it twice to make sure whoever you're asking for help has heard you. And you should be increasing your level of concern using I'm scared. This is a safety issue. I'm concerned. And it gives you explicit permission to use that language. from, the young medical student and learner up to, me as a physician asking another colleague with more expertise in an area for help. You're allowed to say, I don't know what I'm doing. I'm concerned. Something's wrong and I need your help. We cannot have a conversation around this without also mentioning psychological safety. So your team, you want to check and feel the pulse on the thermometer of your team. Is there psychological safety within your team? Does everyone actually feel comfortable saying, I need your help. I don't know what's going on. Can I ask you for help? I know I should know what's going on, but I don't. Please help me. So that goes back to that concept of, is everyone in your team feeling comfortable coming to you, disrupting you, and you will not brush them off? From a physician to the MOA to the cleaner, you will always turn around and say, yes, how can I help you? So take a pulse and a thermometer on your own teams. And if that's lacking, what can you do to improve it? And obviously, Amy Edmondson is one of the big people on psychological safety. And lastly, what tools do we have when we do need to come together as a team to debrief? And I put this picture in because, when I grew up as a doctor, it would usually be this, what did I do wrong? It's the mea culpa. It's me. I did something wrong. It's all on me. It's blaming the provider. And I think we've moved a long ways within team-based culture that we say, no, it's actually not just an individual's professional failure. But often when something goes wrong, we take a systems approach. And that's the lens we have to take. And so I put that Swiss cheese model out here for those of you who might not be familiar with it. It's like your Edam or your Gouda with the holes inside of it. And it's usually, 3 slices of that cheese that somehow lined up the wrong way. And usually we have a couple of different layers of defense. And so when an arrow shoots through, it might go through the first hole, but not the second or the third. But when something goes wrong, unfortunately, in that particular moment, all the holes lined up the wrong way. It's late at night, the physician delivering had already done 6 deliveries and was already tired, got the call. There were 5 calls, urgent calls coming through. The nurses were busy in the other room. So it's usually a layered approach. And then we also have to take a layered system approach to it. So this is a tool we devised at the University of Toronto that we've used actually in teaching. I know one of the questions to us was, do you use that in teaching? Yes, we've used this in teaching with our learners. This is called the fishbone diagram or, Ishikawa diagram. And we have decided that we wanted to use incident analysis and the Ishikawa diagram whenever something happens within our primary care practices and teams, and we need to debrief on it. So I'll give you a concrete one. Measles, mumps, rubella vaccines given to 1-year-olds. Somehow at the end of the season, lots of powders were left and the diluents were all gone. What happened? A lot of kids must have gotten diluents. And that's, I think, not an uncommon primary care incident, to tell you the truth. And so how do we debrief that? So the problem that you see here at the end of the arrow, this is the problem. How can we avoid a whole bunch of 1-year-olds having been given only diluent, not the actual live attenuated vaccine with the powder? So, and then you can break it down, are there some patient factors? Baby crying, first-year resident, busy, running behind an hour. That would be on the provider side. No nurse available to cross-check that they understood that vaccine. Maybe they've never given a vaccine before. The supervisor was in another room helping another resident. Equipment in place, do we keep what we tried is, tape diluent and powder together. So is there something we can do? The vaccines that are already pre-mixed make it so much easier. So there are things about equipment in place that we can make easier. Processes and procedures. You always have to have someone else cross-check. So resident draws up the vaccine, a nurse or a faculty has to cross-check that indeed the vaccines aren't expired, that diluent vial and vaccine powder vial were both used up. So putting procedures and processes in place to protect. And then are there certain policies that you need to look at that might have been overlooked or that you could strengthen to support all of that behind. So there are many different layers that come together here when you analyze an incident and want to put in place all of those different Swiss cheese slices so that they don't all align. And the analysis is based on these, 5 Ps within the fishbone diagram. So here I'd like to hand it over to Jennifer. I am my running partner, so to speak, on the administrative side, because, I've highlighted to you that there are a whole bunch of patient and clinical items, but there are actually a whole bunch of higher level organizational leadership policies and procedures items that we always need to look at when an incident happens within a clinic. And I would love for you, Jennifer, to share your perspectives on that.
Thank you very much, Tia. So in my role as administrator, I'm as the site director for 6 UPCCs and as an employee, of course, of the health authority. The lens that I bring is one of, first, how do we ensure that patients are kept safe? How do we ensure that our teams are supported and that they have the resources and the psychological supports necessary so that when those incidents occur, hopefully rarely, where a lot of questions need to be asked and a lot of resources need to be explored, that the team can feel safe to come together, knowing they're supported and knowing what resources are there to be drawn upon. Among those, so because the UPCCs in South Island, of course, are health authority owned and operated, we fall under the umbrella of the health authority and therefore are accountable to not only the standards of the colleges of physicians and nursing and the various disciplines and to the public, but also the policies of the health authority, and it gives us also the benefit of having those resources at our disposal. So a situation arises, and of course the first thing to do is ask a lot of questions. What is happening? Who is affected? What is needed? And how do we go about finding those things? Among the resources that we have at our disposal are things like our patient safety learning system, which folks from health authorities across the province will be familiar with, in which incidents are reported for the purpose of learning and for the purpose of tracking, so that as Tia highlighted, rarely, if ever, are incidents caused by a single factor or by a single individual. And so the PSLS process certainly assists with identifying trends and looking at how the organization as a whole can address those trends. We're very privileged to have our primary care clinical support team in Island Health. We have several nurses and a social worker and a growing team whose expertise we draw upon to review the necessary literature and resources, college standards and what have you, as we develop policy within the health authority to support our primary care teams. And that team, Nikki is a part of that team, and we're also fortunate to have Stephanie at the front line assisting with ensuring those that information gets to folks. We also, as with everyone, of course, are guided by the regulations set out by our colleges, and certainly by Island Health policies and procedures. We also have the the patient care quality office, who provides an opportunity for our patients to provide both positive and negative feedback, and a means through which we can communicate out to the public in response to that. When a situation is challenging for the teams, my role, a big part of my role, is to pull together members of the organization, groups within the organization who have expertise on what should happen, and where to find the appropriate resources for that. And so while the core team of frontline clinicians are pulling together to huddle, I'm also brought in to ensure that we put in place those resources, and that we also take note of any opportunity for learning, and ensure that we communicate, that we develop the necessary resources as a result of that, and share out those learnings. And so very grateful to have today's opportunity to basically illustrate that we're all learners, and we're all looking to share the knowledge that we glean from the experiences that take place. And so, yeah, that's pretty much what I have.
All right, so we're wrapping up now. I just shared here, if you wanted to look up another guide on building psychological safety, the Harvard Business Review has a really short one that might be useful to your team if you wanted to use that. And then we're going to stop share screening in a second and turn it to all of you. I love the Institute for Healthcare Improvement, because it's very concrete, and it asks you, what will you do by Tuesday? And so I'm hoping that you will discuss with your team using critical language and other tools from Team Scheme maybe by Tuesday. You might delineate with your team, when do you ask for advice versus when do you turn to someone for a consult, or versus when do you just simply ask someone to take over and you will do some other duties within that critical situation. And if you aren't already huddling, change your work calendar to make sure that your team meets often and regularly. Thank you so very much.
It was a lot in a very efficient presentation. Thank you. It's generated so many ideas, and even just the proximity recollection piece of the learning health system and how we're all learners. So it's generated a lot of questions in mine, and my wheels are turning. So thank you. I think it's been great, and I look forward to our breakout sessions. Just before we do get into the next part, want to let everybody know that the recording of today's presentation will be made available on the UBC Health YouTube channel. And a link to this and a quick evaluation survey will be sent to you via email after the event. And I know, as I say, we're going to move into breakout sessions, but I know that some of you will need to sign off. Before you leave, a few sort of business items or messages. First, I'd like to take a moment to remind you about our call, which is out there all the time for panelists for future network events. So being a TBC at UBC Network panelist will give you the opportunity and your colleagues to disseminate any of your learnings and explore any emerging questions in your work or your area of interest to advance team-based practice, education, and research. So if you're interested in being a panelist, please submit an expression of interests form, and that link will be posted in the chat. I'd also like to encourage you to visit our new collaborative space for network members. And the platform provides an opportunity for you to provide your thoughts on what the network's next steps might be and how we move from sort of network sharing to action. And I love Tia's last slide of what can we do by next Tuesday, right? And these little pieces that actually move us from having this conversation and sharing ideas to actually moving this to action. And so we've created a platform that will allow us to perhaps engage all of you in providing those sort of next steps, doable actions that we might be able to move these conversations to. And have even more impact. So again, that link will be in the chat. And one last thing is our next TBC at UBC Network event will be in May. So be on the alert for an invitation to all of you here today. And if you're not signed up and you just managed to connect for this one because you were very interested in this particular topic, please feel free to sign up at the network. And that link will also be in the chat, and that's the health.ubc.ca/TBC. So again, thank you to those who may need to sign off. Enjoy the rest of your day. And now I'd like to have us shift into breakout sessions where we can continue the conversation and perhaps dive a little bit deeper, or have some of our panelists review, answer some of the questions that have come up for you. There will be 3 breakout rooms. Each one will have 1 or 2 of the speakers facilitating the discussion. And soon you'll be prompted, and I'll explain that, to join a breakout room. And the breakout rooms will be focused with the 3 lenses that are typical of the network: practice innovation, education, and research. And we've put together a few guiding questions for each of the breakout sessions. And we'll stay in those sessions for about 20 minutes. And then, so probably until quarter after the hour. And then we'll come back together and just do a bit of a wrap up and perhaps share some aha moments that came forwards either during the panel or during the breakout. Perhaps you have a burning question that you didn't get answered. We'll have about 15 minutes at the end there. So let's see. So to get into the breakout room, at the bottom of your Zoom screen, there is a 4-square symbol, or it may actually say breakout. You may have to click the 3 little dots above the more symbol to find that. And then if you click on the breakout room symbol, then you can click join. And for Mac users, you may have to hover over the number to the right of the breakout room to join. I don't know if that's clear, but We do have a couple of our colleagues here that have asked me in the participant list. So if you have any questions, please connect direct question to our Ask Me participants, and they'll help you get into the breakout rooms. Breakout room 1 will be practice innovation, facilitated by Jennifer, and I will be joining that group. Breakout 2 will be the education perspective, facilitated by Stephanie and Ben. And breakout 3, which is the research perspective, will be facilitated by Tia and one of our network group, Tio, will be joining that group. Thank you. I think that those, I mean, I really appreciated the breakout that I was in the practice innovation side, and learning about what caught my attention was that we had participants from right across the province engaged in developing their teams and at various stages, and really that sort of common wanting to come together and learn from others about successes and strategies to support moving their team-based care work forwards. So this is our opportunity for perhaps for all of you who are able to continue to stay, to ask if there are any burning questions that you haven't had the opportunity to ask, or to share, like I volunteered already, an aha moment, something that caught your attention, and just share with the panel and with the other participants. Talia.
So we were in the group of education, and one thing that Nikki said that actually caught my mind, and there we go. I was like, I had to find you on my screen to feel better about talking about your comment. You commented about how sometimes it can be difficult to get people into do the debrief because perhaps they may not have thought they did anything wrong. But what I really liked about that and appreciated the thought is, even if our staff are saying, no, we don't really have the need for the critical debrief, that there's the opportunity to do so anyway, because that might be identifying in our teams that implicit bias of which they are unaware. So there is learning and potential learning there, regardless of whether they think it's a required or helpful. And I think anytime that we can get our teams together, even to talk through scenarios like that, there's going to be learning from them. So I really liked that piece.
Thank you. I had a similar thought of wow, I would love a scenario critical debrief, because I don't think we've even had a conversation about what our processes would be if we had a critical incident in the practice that I currently work in. So it would, to me, be ideal to run through a fake one to at least start those ideas of processes before actually having one happen. Any other thoughts?
I was just going to say, I think the idea of debriefing, I think it's really important to do it once the incident happens, but I think it's also important to offer that a day or two later when somebody has really processed what's happened. Because I know personally, I've had a couple instances in previous workplaces where that has been offered. And it's been really, really helpful just to kind of, what really did happen when the adrenaline kind of has a chance to get out of your system and to really process it. Yeah.
I would agree. The debriefing, and it's not about fault finding. It's just about putting together all the pieces of things that you didn't observe in the situation, and the whole thing kind of makes more sense once other people's perspectives come in because you didn't even think of that at the time, and it helps with the next one.
I just wanted to say too, I think I've been a part of a few in acute care and then in primary care, and my experience has been different in all of them. I remember being deployed to a different unit in acute care, and there was an incident that I wasn't directly involved in, but was around. And I went, like Laura was saying, the importance of having it after. I went in, I think it was about 2 or 3 days later. I didn't go in because I felt that I needed to go. I had no attachment to the patient who had passed away, but I went to support the nurses I was working with. So I feel like every debriefing is different. I've been in a debriefing session at the Gorge, and I went because I was right in the middle of the action and had to go because I wanted to, because I needed to talk about it. I needed to get out my emotions, and I needed to feel supported by my team, which I did. And so I feel like it's just really important that we realize that everyone will have a different reason for wanting to attend, and they're going to get something different out of it. No matter who they are, they might get multiple things out of it. They might learn from it, and they might just be able to cry and let it out, and that's okay too. So just acknowledging that it's different for everyone.
Carrie, go ahead.
Thanks. Yeah, I appreciate that perspective as well. I was going to ask, because we haven't had any critical incidents yet, so knock on wood, but is it something that typically only the people involved would come to, or is it just kind of open to everybody? And so my perspective is it should be open to everybody as a learning period. But with that, then my question is, how do other sites get people to come in? And I'm on that because in our small clinic, we only have one of each discipline on per day. And we're trying to do even some discipline specific meetings to grasp some of those, PT, for instance. But when there's only one person working, we can't even get the other two to come in for a meeting that is totally relevant to them. And I'm just wondering if anybody has any strategies besides paying them, because we absolutely will.
So I heard I just clarifying, I had two questions. First is opening the sort of meeting to those that weren't involved, to learn and also continue to develop that sort of safety in the team. And then the next piece was, so how do you do that? How do you get them in?
I was going to speak to the part of if they're not involved. In the one incident that I was directly involved with, I was shocked by how many people actually came in that were not involved, because it was something that happened in the evening with just a few of us around, and it made me feel so supported. And I didn't ask each individual person why they came. I'm sure some came for support, but I think a lot of people came because they didn't know what they would do in that situation. And so they wanted to learn from it. But I think somebody else is probably better suited to ask about how do you get people in, other than my only other suggestion is that sometimes it's not as good to have a Zoom meeting, but I mean, it's something so virtual sometimes, but I'm sure somebody else has a suggestion about that.
Jennifer, is your hand up for that one? Go for it.
I wanted to, thanks, just highlight to Carrie's point there, I think there is a difference between a debrief that is focused around the mechanics of what occurred and the learnings from that, and also a psychological debrief that is very much needed in many of these circumstances. And the two aren't necessarily done together. And in some of the situations that we've dealt with, they've actually been done fairly separately, so that individuals may participate in both, but not at the same time. And in my experience with debriefs, once people become aware that they are happening, just as Nikki was sharing, it's surprising how much uptake there will be, particularly if people hear, oh, that debrief was really helpful, and then another situation arises and they think, okay, maybe this is really worth my time.
Thank you. Sarah.
Yeah, I was just going to comment on, I think one of the biggest things that at least has been my observation and big learning point in team-based care is that oftentimes we can kind of end up in our professional silos in settings that aren't necessarily centered in team-based care. And when we get the chance to kind of come together, and instead of like the sense of identity or collective well-being is in the team setting, and as opposed to, for example, explicitly within your own professional group, and that really fostering that culture changes people's buy-in to things like debriefing, for example, where it's not just about the individual experience, it's actually about the collective benefit of the team. And I think that part of that too is that it's inevitable, if we've existed in the healthcare system for some time, that we have stories that are told about our colleagues in their professional groupings, and that means can be assumptions about scopes of practice, or assumptions about competencies, or assumptions about all sorts of things in terms of how, based on the title that we carry. And something that's been so, I think, helpful in our team setting is that we're there to learn about each other. We're there to learn about what each person brings to the team, not based on their profession, but based on their own kind of, what's in their toolkit based on their professional experiences and also just their personhood. And that, we were kind of as a team sort of working on fostering an environment where we can center those things. We have a lot of newcomers or clinicians that come in for short times. And I think that that's just part of, changing the culture to be not just about our professional identity individually or again within our professions, but as a team. And certainly these things around debriefing or like morning huddles and things really help set the tone for that in a day. But I do think that really influences how you get people to show up, because they're showing up with a sense of belonging and like I say, collective care for your team, as opposed to just yourself as a provider or within your own professional grouping. So
I love that term, collective care. That's a great term. You have me thinking because you referenced the fluidity of healthcare and that team members change and have me curious on how much this is likely daily work to maintain psychological safety amongst members, especially with team fluidity, and the other processes. I know that we're looking at critical incidents as one piece of this, but the other processes of developing those team relationships and that psychological safety, considering that members change. We have a couple more minutes. I had one question, and that is there any experience with learners participating in this? Tia.
Yeah, I'm very happy to share. And as I said, I'd love to bring Greg's wings to this, put a plug in with Ben for next year, if you want to have me again. So Team Scheme was actually devised out of Greg Price's young death due to testicular cancer and his journey through the healthcare system. And it changed the Alberta healthcare system significantly. And then essentially through this really moving story and captured in a well-made movie, has traveled kind of from the University of Calgary to all across. And within it too, we devised a whole bunch of teaching tools. Team Scheme is one of them that, we shared across the different departments, faculties of medicine. So both undergraduate medical school and in my case, family medicine residency programs, but beyond just the departments of medicine, but I know many others, pharmacy, nursing, social work. So there are a whole bunch of tools that we can share that today are anchored within many of the undergraduate medical schools, so that they are well versed in speak up, use critical language, don't be shy. And I think that that's so important. I certainly think in my days, I can think back many moments where you don't want to be the stupid learner. And how do I say it without appearing really stupid? But I do need to ask for help because I don't know. And so I think that's kind of within, so patient safety. And then the incident analysis tool, as I mentioned earlier, it actually came from our family practice residents, because as I said, I was just at one point checking, why do I have all of these powders and where are the diluents to it? And so, one of my assigned residents, now an emergency room doc, needed a quality improvement project. And so he said, okay, I'll sit with you and we'll devise we'll do incident analysis. We'll teach all of the family practice residents on this tool. And we got that across, I think, most of our teaching sites at the University of Toronto, at least 9 of them. And to be honest, when we started the conversations, our faculty felt uncomfortable. It's like, that picture of, oh my God, really, do I have to talk about it? Because when something happens in our generation of teachers, it's like you had to deal with it on your own. Shame, right? And while what we wanted to really teach our learners is, no, we have a language, we can debrief together. There's a safe way of doing that. It's a system issue. And how can we improve as a system and as individuals, obviously, so that it in the end will produce better and safer patient care. So I'm happy to share any of that in the future.
Wonderful. Thank you. And I think that that's a very good place for us to end. We could probably speak for the rest of the afternoon. And so thank you again to our speakers for sharing your wisdom with us today. And also for helping us facilitate our breakout sessions. Thank you for everyone who's managed to stay. We've gone a few minutes over and contributing to the conversation. So our aim, again, is to advance team-based care in British Columbia, and we may bring you back to you next year to look at a different perspective. Thank you. And our next TBC at UBC Network event will be in May. Please watch out for the invitation. And if you're not signed up, please go to health.ubc.ca/TBC. And we hope to see you then. Thank you. Have a good afternoon.